I want to thank CanMed very much for inviting me, and it's like I'm going to say Michelle, who spoke earlier from Columbia Care. This is the first cannabis conference I've been to since COVID, and so it's great to see some old friends, see some new friends. Sister Laurel, how are you? And some dear friends on the panel here. I've known 3 of the 4 I've been in this industry for about 10 years. My wife and I, Corinne, I'm not going to get emotional now, started this journey in 2010. Cannabis wasn't our lifestyle, and I'll just do a Cliff Note version. My father-in-law was diagnosed with stage 4 lung to brain cancer, and he was on 24/7 oxygen, and he was declining every day. So every morning we would call to make sure, did he make it through the night? And I said, I'd like to go to your next oncologist appointment. And we went. And Corinne and I found a study that showed 40% of cancer patients pass some malnutrition before cancer takes over. So while we were in the oncologist office, we asked, how much time do we have? And his oncologist said, 2 weeks. And through tears, more from me, my father passed about 1.5 years prior, not from cancer, but from a heart attack. Her grandparents are still alive, 98, 97. They were together since age 16, so if that's not a beautiful way to live. And I said, what about cannabis for appetite stimulation, not knowing the true medical benefits of this incredible plant? And I called Corinne Mary Poppins because she didn't drink and she didn't smoke, and I said, deem her the caregiver. And we did, and we went on this journey, the blind leading the blind. And back then in 2010, 2011, there was no guidance. There wasn't top doctors in this industry, scientists that were really out there talking about the benefits of cannabis. Dosing, there was nothing about dosing. You would say enough for one person, but it was really enough to feed a whole NFL football team with what the dosings were. So we found a coconut, gave him a piece of chocolate, knocked him on his behind, and we found a coconut capsule that the reason we went that way allowed us to freeze it and cut it into slivers. And within 24 hours, he was eating. And 6 months later, hospice fires him as a patient. At 9 months, he was never going to get scanned, and he came back with no evidence of recurrent disease. We said, wow, this is a miraculous plan. So we went on this journey to educate. Education is the key, not only in life, but especially with this plant. As the laws in the United States are growing for cannabis use, the lack of doctors' knowledge is far, far behind. And so it's tough when a patient calls, hey, my doctor just recommended cannabis, what do I do now? And that's frustrating. And so conferences like this, I look at it as the ripple effect. Pebble in the pond, ripple effect, the education that's going out. And so what we've learned here this week, we'll take back to our home and share with our doctors, our families, our patients, et cetera. 2017, my wife was diagnosed with pancreatic cancer, and she passed 4 months later.
Correct.
To me, success with this plan is saving a life like we hit a grand slam with my father-in-law. Other success is getting out of bed, seeing your loved one, sleep, pain relief, wellness. And so I continue this journey. This is real life for me, and I know it's real life for a lot of people who've been into this industry and who changed their whole careers. Eloise has worked with us for years. She was an oncology nurse. To see all these patients passing away from chemoradiation, it was affecting her health, and she saw the benefits of this plant. She changed her whole career. Bonni Goldstein, the same thing. UCLA studied, medical doctor, saw the benefits, really took a step forward. I mean, Dustin and Kevin as well, putting their reputations on the line. And it's nice to see that the stigma of this plant has really dropped, because before it was hush, hush, hush. We're not really going to talk about it. So anyway, I'm here proud to represent the medical cannabis community and where we're going. I'm here with some colleagues that I admire, and I look forward to where this industry is going. They're rock stars in this industry, if you have not already realized that. We have a resident singer in Eloise Theisen, so thank you for that as well.
Yep.
So,
I'm booking shows into 2023, so after.
so how many patients in the audience? Good to see you. Yeah, I think we're all patients, yeah, but good to see you. And, don't be afraid to ask questions, because it's not illegal to ask questions. It doesn't matter where you live here in the United States. In some countries it is, but don't feel this is your body. If your doctors aren't open to this, ask them for a recommendation for another doctor. And so I'd like to start off with Dustin. One thing that you taught me and I share with a lot of people is sitting there, taking a deep breath, and just taking a body check. And so I know I don't want to say we're saving the best for last, but thanks for sticking around for this panel here. But can you share, I love what you do of what that body, I know you spoke about it at the medical practicum on Tuesday, but if you can share it with the audience too?
Sure, I'm happy to. And for the amazing AV crew in the back, if there's any way to get more monitor on the stage so we could hear John more clearly, that would be great. So, probably about 7 years ago, I was wondering how to help my patients detect a kind of subtle change in the way that they're feeling based on a certain dose of cannabis, because I became very interested in using the lowest effective dose to nudge the physiology, using a term from Kevin, so that we don't overwhelm one's physiology and we can work in concert with the endocannabinoid system instead of undermining it. And I developed something called the inner inventory, which is nice. It feels good, and it just takes about 30 seconds. So we could all do it together right now. And the way I recommend my patients do this is to practice the inner inventory, maybe write it down. In fact, our healer products come with little workbooks and worksheets, so you can keep track of how you're feeling with certain doses of cannabis and really get a highly individualized treatment regimen. So there's 3 measures. It could be 4 if there's a symptom that you're experiencing and you want to check in with that. The first one is breath. And so you're going to rate on a scale from 1 to 10 how smooth and easy your breath is when you just take one nice deep inhalation and exhalation. And so you could just think about what that number is for you. For me, it's 9 right now. And the next measure is body. So just whatever position you're in, just kind of remain still there and rate on a scale from 1 to 10 how comfortable that is. And I'm at about a 6. And then the next one is mood. So you could rate how content you feel at this moment, or you could put a fake smile on your face and give it a few seconds and see how real the fake smile becomes. And I'm like 9.5. Oops. And then you could rate a symptom. So say you were going to inhale some cannabis, you would maybe recheck that in 15 or 20 minutes. Or if you were taking some oral or oral mucosal cannabis, recheck that in about 90 minutes and see if that dose affected you. Now, other things might have happened in that time that could have changed your inner inventory score. And the secret is that just checking in with yourself is probably going to make you feel better. But that's a good thing to do anyways. If we can kind of capitalize on this placebo effect and make ourselves feel better just by paying attention to ourselves, maybe giving a little self-love, that's just helpful. So there we are. Thanks for checking in, everybody.
Thank you. And you are right. I can't hear you from here. So in hearing all the other speakers saying, I didn't catch that, I don't know, can you turn this on? This.
I think it's the side one pointing at us might be helpful.
Okay,
but
so anyway, I wanted you guys to introduce yourself as well. And so, Eloise, if you'd like to start.
Sure. I have new initials. I'm Eloise Theisen, no. No, I'm an adult geriatric primary care nurse practitioner. Yep.
And I'm an osteopathic physician, a traditional osteopath. I've been practicing in Maine for 13 years and using cannabis with my patients that whole time.
I'm a pediatric trained physician here in Los Angeles, and after doing pediatric emergency medicine for many years, I switched to a cannabis specialty practice about 14 years ago.
And I am a phytotherapist, and let me be clear, that's not using small dogs as therapeutic agents, but phyto as in plant, or in the States we say a clinical herbalist.
Sense of humor.
Thank you. So, I always say cannabis is not a one-size-fits-all type of medicine. Age, weight, current health condition, sensitivities, stage, and drug-to-drug interactions. And so I was going to get into drug-to-drug interactions, but let's talk about, this one comes up too, and Bonni, you spoke about this earlier, is I want the medical portion of the plant, not the recreational portion of the plant. And we spoke about THC. There's a lot of benefits of all the cannabinoids. When I usually present, I usually have a wall with a roll of duct tape up there, and people look at me like, "Hey, dummy, you have the wrong slide up there." And I kind of laugh because when people ask, "What about this? What about this? What about this ailment?" I don't want to say it's like 1,000,001 uses like duct tape, but when you really get down to it, it really is. And there's so many. Each cannabinoid plays a role. THC, we're here in California. My brother's in the wine business up in Santa Barbara. It's like, we can have a sip of wine, sip of wine, sip of wine, and wine tasting. And the same thing with THC, and you've always shared that less is more. So can you talk about the less is more, and not only beneficial because it's not covered by insurance yet, but also saving money, but also you might find your sweet spot at the lower amount. Would you like to talk on that? And the same thing down there with you, Kevin, please?
Sure, I'll just jump in real quick. Bonni showed nice slides earlier that depicted the internalization of the CB1 receptor when it's overstimulated. Now, we have heard over and over again how important this endocannabinoid system is in responding to illness and injury, in supporting our growth and development, our neuroplasticity. We want that system working as efficiently as possible. And when we build tolerance to THC, at least to some extent, we are decreasing the capacity of that system to keep us healthy. So, one of the nice things is that it's easy to reverse tolerance to THC. It happens probably more quickly than a lot of other agents, but so it's not like a lot of harm done, and maybe even a useful lesson learned from overusing THC and building tolerance to it. But what I see with my patients is when each person has kind of figured out their optimal dose of cannabis, the retention of efficacy could be decades. I mean, they really don't lose the beneficial effects, and over time they tend to use less and less cannabis. The dose goes down slightly. We saw that in Ethan's slide this morning, and I think that's because we're becoming more balanced inside. We're establishing a greater homeostatic capacity, and people are healing. When we're less sick, we tend to need less cannabis. So that's my perspective on always using the lowest effective dose. And just to comment, that this whole, I think it came from CNN, this, like a lot of other things, this whole concept that CBD is medical and THC is recreational is just crazy. And I think you all know that, but for anyone in the audience that hasn't realized that yet after listening to all these panelists today, THC is an incredibly powerful therapeutic agent and quite versatile. It does not need to be psychoactive. There's almost always in every patient a therapeutic window where there's a certain dose of THC that will create beneficial therapeutic effects, and then a higher dose that'll start to create potentially adverse effects, which might be impairment or unwanted psychoactivity.
Thank you.
Yeah, and I'll take it from the 30,000 view, since Dr. Sulak just did such a good job of explaining it on the cannabis level. So there's a concept that goes across all biological kingdoms, and it's called hormesis. It's had several names over the last decade. Today we know it mostly as biphasic response, and essentially what that means is that a low dose can be incredibly beneficial, and a high dose can actually even be toxic, if not damaging. Right, so the concept there is that finding the right dose is really key. So dose titration, or slowly scaling up your dose to that optimal level, is something that I used to do with other plants besides cannabis in the clinic. I mean, I think it's really, really key to recognize this. Interestingly, a quick story on this is that in the so the homeopaths back in the early to mid 20th century were looking for a way to explain their medicine scientifically. And of course, if you understand homeopathy, truly understand homeopathy, we're going to have to change the laws of physics and chemistry to really be able to embrace homeopathy in a scientific way. Not that it doesn't work, I've seen it work, and I've seen it work in laboratory situations as well. But they needed a way to explain it, and so the hormesis concept was really big in the earliest 20th century. In fact, there were multiple journals dedicated to just that concept, that low dose could be very beneficial and high dose, and they were talking about toxins. For example, the guy that has brought it into modern age found by trying to poison a plant that he actually made it grow more because he diluted the poison too much. And I'm not saying go out and drink poison. Get me clear here. That's not what I'm saying here. But that concept of one dose having one effect and another dose having another effect, that biphasic response. So the homeopaths jumped on this model. They were like, that's how our stuff works. Really low doses of whatever it was, whatever the homeopathic remedy was, aconitum or arsenic, or, that's how our stuff works. Well, interestingly, in a very political move in the sciences, which we're supposed to be immune to, the concept of hormesis dropped off the map. And Edward Calabrese brought it back in about 1980. And so now there's hundreds of publications on hormesis. So interesting story there. The homeopaths kind of we lost the concept because of the homeopaths.
And I just want to add one other thing about the homeopaths that a lot of you might not realize, but this whole breaking cannabis down into two things, cannabis indica and cannabis sativa, this was an early homeopathic concept. They had two different cannabis remedies that had some overlapping but distinct features. And again, these were just incredibly small quantities of cannabis, like to some extent diluted beyond Avogadro's number, where you're just getting an energetic essence of cannabis and no actual molecular content, potentially at least, and that there were these differences among this plant. And so thanks to the homeopaths for the whole indica sativa nomenclature nightmare.
And by the way, that's a really important point, is people say homeopathy when they really mean herbal medicine, and they're not the same, right? What Dr. Sulak was just talking about is dilution beyond Avogadro's number, which basically means technically there's one or two molecules in your remedy, depending on how diluted the remedy is. So that's why I'm saying they'd have to change the laws of chemistry or physics to really be able to scientifically explain homeopathy.
Thank you. The discussion of products comes up quite a bit with patients, and so Bonni, you and Eloise spoke about, now there's an overabundance of CBD, and now you can't find the good products, the THC products out there. Can you explain the difference to patients of medical products versus recreational products?
Okay, so they all can be used for either, right?
Yeah.
I mean, CBD, dominant CBD, you might have to drink the whole bottle to get a little buzz going, but for anything that has THC in it, it can be used recreationally, it can be used medically. So I just had this come up with a patient where a parent went in to a dispensary to pick up a product, and the person behind the counter, because she has a letter for a child and a caregiver letter for herself, they knew she was there picking up a product for a sick child. And the person behind the counter said, well, that's not a medical product, that's a recreational product. Well, I don't know really what that means. I want these compounds in this dose to try with that child. So why are we labeling medical versus recreational? Now, certainly something that's 90% THC, I think we could all probably say that that's leaning more towards the intoxication goal. But at the same time, I have some chronic pain patients, adult patients who suffer terribly and have used very high potency just to be able to step away from their pain even for an hour. You don't get to take your back pain off or your botched back surgery and walk away from it and then come back later. So how do you disassociate is you can use this medication to step back and distract yourself and maybe focus on something else for a little while. So I don't make a distinction between medical and recreational. I'm all about what's in the product and what's the dosing for that particular patient.
Yeah, thank you. Would you like to add that? No?
No, I think she covered it well.
No. Eloise, no.
No. I mean, I agree with Bonnie. There's, in California, there's no real distinction, right? They try to distinct it by what license you get, but the products are all the same. And, I wish that we could see more products that had more versatility in the THC world. We're just trying to make more and more concentrated products. And I think we're missing a large population that, I wish the industry could appreciate, and I think it was in, now I'm forgetting her name, doctor, who did the opioid talk?
Oh, Shuffett.
Dr. Shuffett.
Shuffett, Dr. Shuffett, was talking about, the people come back when it's medical, when they're using it medicinally, they come back and they purchase it, and they purchase it multiple times a day. And, that's a market that we're missing here, an opportunity to really, provide for these patients when we're just focused on cannabinoid content. I'd like to see us provide more variety for consumers and healthcare consumers and patients.
Yeah. Bonnie, you and I have had this discussion over the years, with California passing the 21 and over, and I'm seeing this in other states as well, it's pushing out the true medical professionals, because a lot of patients now say, I don't need to go to the doctor. I'll just go down to the dispensary. And it's unfortunate, because I truly believe, especially battling something as serious as cancer, a medical professional should be involved. A senior citizen, we're not 21 and 19, 20, 21, like, ooh, won't do that again, type of thing. There's so many products out there, especially CBD products. It's confusing. People ask me, what about this? I mean, there's times that it's hard to point them in the right direction. This topic comes up all the time, and I know, Bonnie, you and I have spoken about this, about suppositories. Is there any bioavailability in there? Because that comes up quite a bit. Years ago, Corinne and I wrote an article about, is the posterior superior? We got a lot of shit about that one, believe me. And so we had to take it down, because there was a lot of fighting on that one. But I don't want to I'm not into giving false hope, but I'm into giving hope. And if eating this flower worked with a cancer patient, I'd say eat the flower. What are your thought process on different products, especially the suppository discussion, because it's coming up quite a bit, and some people say it's working, and I don't want to say what you shared. If you can add to that.
So there's a few ways to look at this. So number one, if we look at the clinical research, right now there is no evidence that just cannabis alone in a suppository will be absorbed into your bloodstream at sufficient levels. So if you have a suppository, that there's a study that shows that the cannabinoids, if bound to a compound, in this particular research used the drug called hemisuccinate, which is what we call like a permeation enhancer. It helps bring it in. It helps cross the barrier that you have to cross over to get it into your bloodstream. That actually showed some very good success, but that is not what, as far as I know, what's available on the market in California. I have had patients who report, especially cancer patients back in the day, that they reported that they were doing well. But remember, they weren't just doing suppositories. They were also on chemotherapy. They were also on vitamin C infusions. Some of them were taking mushrooms. Some of them were taking vitamin C and all kinds of other concoctions. I think it's a very nice thing that they wanted to believe it was the cannabis that was working. But when you have so many variables, you cannot say what is working. If you have THC in your bloodstream, you should have some effect in your brain if it's in your bloodstream at any, a significant level that we would think that would be needed to help kill cancer cells. However, in my experience, I always learned that cancer patients should not be putting anything up their bum because you're at lower immunity and you can introduce bacteria into your bloodstream and get septic. And if you read about this, this is a real thing, that you can develop sepsis, especially when your immune system is not working well. In pediatrics, here and there, when I first started in this, some parents were trying to put tincture rectally to stop a seizure because there is a drug called Diastat, which is a rectal Valium, which will stop a seizure. That's clinically proven. And parents would say, oh, the seizure stopped. And I would say, well, the seizure's going to stop anyway at some point. And you don't know if it's the cannabis or not. So we need to have a clinical trial to see. However, in general, that's kind of like most people don't do that anymore. I think they would rather not do that to their child. But in general, I am not a big fan of suppositories. I think it's kind of a waste of money, and unfortunately, there are still a lot of products out there, though, that are being used that way.
I'd like to add a couple of things. I think that suppositories can be useful for local problems. So if somebody, hemorrhoids is a good example, a very common condition, itching, pain, inflammation. THC is great for all of those things. Vaginal pain can respond to THC. I think that some patients do absorb THC through their rectum because they feel high and they feel euphoric and good, and whatever that patient preparation combination is, great, that works. Well, I think where Bonni was going is that we just hear about a lot of people that say, I need to take these heroic doses of THC, but when I do them by mouth, I get so high I can't take it, so I'm going to insert them rectally and just assume that they're getting into my body and I'm not getting high, so it's a great way for me to avoid this adverse effect. And there's one mechanism that might explain that, but it cannot explain it fully. That's that when we swallow things, all the blood from the gut goes to the liver first, and the THC gets converted into an active metabolite that's called 11-hydroxy-THC. Might feel a little stronger for some people, but really that's not a full explanation. So I just wanted to add that. And then, you know, when you say some people said that the rectal THC was helping them, even though it wasn't getting them high, I just want to point out that there is something very, very interesting happening in the ultra-low dose range of THC, but there's a lot more cost-effective way to get that ultra-low dose range than putting a whole bunch of it up your butt.
And a lot less invasive and intrusive.
Right. Yeah. And one other thing, there is a study on CBD for in a rectal suppository for colitis. So, and remember, that's kind of like local application. So that's what that looks at.
Kevin, you want to add anything? You'll say. So are there any contraindications, you know, with patients that, you know, liver, schizophrenia? Is there ever a time where you totally route patients away from cannabis?
So I had someone in my office who was full-blown psychotic, and I kind of didn't trust her judgment just in general. Yeah. And so I told her that this is many years ago, I told her that I could, you know, see her if a family member would come back with her just so I could get the full picture. I mean, she was going off on the people next door, got the tinfoil and the, you know, the cameras and stuff. And so I just felt uncomfortable because I really wasn't sure what her status was, and I'm not a psychiatrist, so I'm not qualified. Do I think cannabis would have helped her? Yes, but I just felt uncomfortable at that moment in time. I have a young man in my practice who's been my patient for 13 out of 14 years that I've been doing this, who has schizoaffective disorder. And what I did with him was in California, we normally give a letter for a year, an approval letter. I gave him an approval letter for 1 month, and I made him check in every single month with me so I could just see his progress. He had the typical type of unfortunate course with schizophrenia where he would become psychotic, get hospitalized, go on medication, do very well. He hated his side effects. He would go off medication and then end up in the hospital. It was this vicious cycle. And I'm happy to say that in 13 years, using predominantly THC, because we didn't have CBD back when he was using it, he has managed to not have one hospitalization. He has not gone off his other medication. Low-dose THC has helped him. So it can, you can successfully treat people. And I would, here and there, I would get older adults come in with their children who were adults and say, my son is smoking pot, but boy, it's so much easier to live with him with his schizophrenia. He's calm, he's not destroying the house, he takes his other medication, he seems to have some joy, because one of the biggest problems with schizophrenics is they have no joy in life. And when you hear a parent coming in and telling you, this is what's happening, it's very hard to deny. And I remember this is back when I was first doing this. I felt very comfortable recommending cannabis to those families because there was a caregiver involved and they're reporting to me what the results are. And they're the ones that are living with the patient.
I don't think there's any firm contraindications for cannabis. I think one area that we should be extra cautious is in cancer patients that are undergoing immunotherapy, especially the nivolumab drug, which has been published in 2 studies and shown. So this is a type of cancer treatment that it revs up the immune system and causes a lot of inflammation in the body to help the immune system fight the cancer. And of course, with cannabis being an anti-inflammatory compound, we have to be cautious about not dampening down the effect of that drug. But I wouldn't even say that it's a firm contraindication. For example, we know that corticosteroids like prednisone decrease the effectiveness of those treatments, but sometimes when people are on those treatments, they'll develop too much inflammation. They can get pneumonitis or colitis or reactive skin conditions, eye conditions, and they'll be given prednisone to help settle that stuff down and still remain on the treatment. We know there's a lower rate of efficacy, but still they can complete the course. And so I think cannabis could be viewed in kind of that same light. It should be used with a lot of caution, but not a firm contraindication.
Thank you. You want to add to that, or you want to follow?
No.
No. Just like it says right there, right? So what about, so Eloise, you work with a lot of patients, and what about cannabis use disorder? That follows up on some of those maybe contraindications with maybe a patient who's schizophrenic.
Yeah, I mean, there's definitely diagnoses I'm not comfortable working with. I don't feel qualified to manage, and a lot of them can be complex mental health conditions. I have a patient right now who is quite interesting. He's got pretty significant post-traumatic stress and came to me already consuming 200 milligrams of THC. 100 milligrams at a time, twice a day. And his psychiatrist was on the call with us and just said, wow, you know, when he takes these dosages, our therapy sessions are incredible. Like, he's so open, and I've just seen so much great progress in him. Now I'm starting to see him rely on the THC in a way that's making me uncomfortable. I've increased him to 300 milligrams, so his dose is 3 times a day, but I do think we're starting to see, I'm not sure if it's cannabis use disorder or CB1 downregulation, but my concern about cannabis use disorder from the non-medical cannabis community is I don't know that they're qualified to be making these diagnoses when they don't really understand the endocannabinoid system, they don't understand the complexity of legalization and prohibition, and so I think it's grossly overdiagnosed in patients, and I'd like to see it, you know, like I said, there's diagnoses I'm uncomfortable with, right? I'm not going to diagnose somebody with post-traumatic stress. I'm not qualified. I don't know that some of these clinicians are qualified to diagnose cannabis use disorder. But I think it's a conversation we need to be having in the community because it's very divisive. And I would like us to be more open around, you know, I see many cannabis professionals try to deny that cannabis use disorder exists. I think I can count on like 2 fingers how many times I've actually seen it out of, you know, over 7,000 patients. But, you know, we do need to be aware of it. We do need to be thoughtful about it, like as Dustin was saying. You know, I don't know that there's contraindications, but we need to be so thoughtful about how we approach these patients.
Can I just make a comment? So when we look at studies on young adults using cannabis excessively or what they call chronic heavy use, really what it comes down to is poor judgment. How many people know a 15-year-old to have good judgment? I mean, I just survived my son being a teenager, and he wasn't a difficult teenager, and it was still very difficult. So I think I would see, back in the early days of my career being a cannabis specialist, I would get 19-year-olds that would come in and 21-year-olds that would come in that had legitimate medical conditions. You see gymnasts, in high school, they beat up their bodies. How about the kids that play football in high school? I mean, I had a kid in my practice who's had 4 shoulder surgeries by the time he was 16. Well, he got offered pain pills, or guess what? His buddies gave him some cannabis. Is that a cannabis use disorder? Now, by the way, he takes cannabis, he feels better, so what does a 15 or 16-year-old do? They take more. It feels good. More. They have no judgment whatsoever. So the idea of this cannabis use disorder that kind of stems from that kind of chronic heavy use in certain age groups really is just a lack of judgment, because I will share with you that with continuity with these patients, because remember, before 2018, you needed me to approve you to get into the cannabis dispensary, right? So these kids that I would see, let's say 18, 19, 20, with legitimate conditions, it was a very interesting phenomenon. It was usually male, because I think women are a little more risk averse and a little more thoughtful at that age, or maybe just more mature. But every now and then I would see somebody who would come in and they'd be 23 or 24, and I'd say, gee, I haven't seen you in a while. What's going on? Oh, I took a break. And then, I stopped using cannabis for 5 months. I realized I was overdoing it. And I would put my hand across the table and say, welcome to adulthood, right? They're being thoughtful about their use, finally. And some of that is just being mature and being ability to start listening to your body, and instead of just kind of going along with the program, so to speak. I hope that makes sense.
I'd like to make a couple comments about that. It's interesting because from time to time, patients come to me, the most recent traveled from out of state, with self-diagnosed cannabis addiction, looking for my help getting off cannabis, which I'm happy to help with. My initial response is thank God you're addicted to cannabis, right? It's not cigarettes or alcohol or stimulants or opioids or a number of other, tobacco and a number of other substances. And, I think kind of a progressive way of looking at addiction is that the drug isn't the problem, but the drug is the solution. And there's some underlying problem. So we work together to figure out what is this underlying problem and how can we best address it. And often it's just a different use pattern of cannabis that can address it. So for this most recent patient who, she had a very unique response to cannabis. She literally had to smoke every 2 hours or she would have a panic attack, get up in the middle of the night to smoke and so forth. But by shifting away from THC dominant to type 2 cannabis varieties with more CBD and less THC, gradually reducing her dose, layering in some oral dosing, all the meanwhile getting to the underlying problem, now she has a balanced relationship with cannabis that's no longer problematic. And I think, cannabis is just so versatile. The diagnostic criteria for cannabis use disorder is almost almost any cannabis user could fit into it. It's like you go to extra trouble to get to get this substance. I have to drive to the dispensary. But really what it comes down to, I think, when I'm working with my patients, and this is an important transition point for people who are healing, using cannabis for healing. The question is, are you feeling better after you use the cannabis, or are you feeling worse after? And it's interesting, as people get healthier and healthier, they've been using cannabis as a crutch for a long time, suddenly they don't need it as a crutch anymore. If they keep using it that way, they're gonna take some and be like, wow, I actually felt better. But if you didn't ask them that question, they might not realize it. And once they hit that point, that's a celebration. Now we can kind of shift cannabis into the form of a tonic, like something that you can use to improve your resilience to stress, to stay healthy, to treat acute illnesses and symptoms, but it doesn't have to be this kind of daily, all the time management strategy for you. So it's, I think an important question is like, are you continuing to use cannabis despite the knowledge that it's making you feel worse or that it's interfering with your life? If it's a yes, then there's something there that needs to be changed.
Love it.
You're okay?
No.
No. So following that, so a daily use patient, you know, we hear this, I don't want to be, is cannabis addictive? I think it's habit forming. I don't think it's addictive. Is there a difference?
There's psychological addiction versus.
Yeah.
Right.
Yeah.
Well, I mean, I think maybe what you're alluding to is this fixation, like when people have their attention fixated on the cannabis and it's like starting to consume their life. And that I have seen, and I think there's certainly a way to kind of synchronize with that individual and help them kind of restore reward to the natural pleasures in their life. You know, cannabis is often the solution to the problem that cannabis chooses. It's just, you know, or the problem that cannabis causes. It's just an evolution in that individual and their relationship with the plant. And it is a living, dynamic relationship, right? And I often feel like I'm not the teacher. Cannabis is the teacher. Maybe I can help interpret what this teacher is saying to the individual so they know how to listen to those lessons and respond and make the changes that are indicated.
And I would like to say there is a described cannabis withdrawal. It's THC, and it's usually only after very high doses for quite some time. I have seen it in pediatric patients. I had 2 patients, different types of cancer, both children very young and very sick, where in California they were receiving, from my protocol, getting chemotherapy from an oncologist, usually some dietary changes, and then we were using high-dose CBD and THC. Of course, THC was titrated up, and they were using it over time, and both of them ended up being accepted into clinical trials in other states, and the parents at that time, you're talking quite some time ago, they were afraid to travel with it, and neither of them really updated me that they were going to be leaving town without their THC after their child had been on THC for a while. Because what I would have done was weaned it down, not abruptly stopped it. And I got calls from both of them. A child was at Sloan Kettering, and actually a nurse practitioner called me and said, this kid is just wigging out. And I said, well, that's what happens when you stop high-dose THC on a dime in a small child. And really, what is that? It's that downregulation of those receptors like I showed in that picture. And now we're just kind of waiting for those receptors to kind of come out. And what he just was irritable, and he didn't really want to eat anything. And it was over in just about 4 days, I'd say, but he was kind of miserable those 4 days. And so there is, and in adults, that if you've known anybody who takes a high dose of THC on a regular basis, if they stop abruptly, they might feel lousy for a little bit. And it's usually not so bad. They talk about it's a 2-week period. And usually the first 3 to 4 days are the most difficult. A lot of people who want to abstain or cut back, by that day 3 or 4, they kind of can't take it, so they go back into it. And this is why oftentimes, in my experience, what I'll do is just continue the CBD, because that will help mitigate some of the symptoms, and then just wean down the THC. And you don't have to do it slowly. I've usually basically take 25% of the dose away every 3 days, and that seems to do the trick. That's just my protocol that I came up with.
And I think one of the gifts of cannabis, so everybody's different, but the typical cannabis withdrawal syndrome will begin usually around 48 hours. People might feel a little off for those first 48, but the irritability and loss of appetite and trouble sleeping usually kicks in around that 48-hour mark, and that's actually about how long it takes for people to upregulate their CB receptors and become more sensitive to cannabis. So if somebody stops cannabis for 48 hours and jumps right back into the dose that they were using beforehand, they'll have kind of nothing gained from that experience. However, if they start at a lower dose and just use the lowest effective dose to mitigate those withdrawal symptoms if they're having them, or to cause like a change in their inner inventory, then they're actually contributing to this upregulation of their their endocannabinoid system. Now that statement is based on some preclinical data and what I've observed in the clinic. But in general, I think that this is a really forgiving part of this plant also, that if we build tolerance to it, we can reverse it quickly and effectively without having to endure a brutal withdrawal period. And CBD can help with those 48 hours, exercise. There's all sorts of ways to successfully sensitize one's system to THC and to cannabis. And we have a free program on healer.com that'll walk you through that, hold your hand, show you videos, give you worksheets, and other activities that you can do to be successful with that. If any of you are regular, moderate to heavy cannabis users and you haven't tried taking a 48-hour break and sensitizing your system, I highly recommend you give that a shot and see what you find.
Yeah, and I think what is really important here too, I've seen withdrawals with CBD, high CBD use, but I think what's really interesting is if you've ever had a patient go through withdrawals from opioids or SSRIs or other medications, it's nothing compared to the withdrawals they might have from cannabis. So, I always tell them, yeah, you might have a little diarrhea, you might be difficult to be around, but it'll be over quickly. I mean, my personal experience with opioids was a month of withdrawals and symptom management. And when I said, how long is this going to last? They said a week. And I said, well, I'm in week 3. And he said, 4? I mean, they just don't know, right? And they don't offer you any solutions. So the good news, at least with cannabis, it's a lot easier to come off of if you need to.
Thank you. Following that, what about hyperemesis syndrome with the patients that or I guess is it normally just with too much THC? Is it normally that you're seeing it in teenagers and 20s and 30s, or?
It's THC related.
Yeah.
It's usually not medical cannabis patients, although I've seen 2 cases in my career. So it's in my career, it's not very common, but I got yelled at by a GI doctor who yelled at me and said, it's all over the ER, so how come you're not paying attention? Well, because I work in the medical side of this, not the adult use / recreational side, or where teenagers are just doing it without some direction or self-medicating, and again, poor judgment leading to overuse. But the 2 cases that I saw were people who went from kind of what I would call moderate THC use to the very high potency dabbing and the concentrates. And one patient, it took 6 ER visits to get the diagnosis because she didn't disclose, and for whatever reason, they never did a tox screen. They thought it was a pelvic inflammatory disease or a ruptured appendix. She got worked up for a ruptured spleen, even though she had no sign of trauma. I mean, so there was a lot of money spent on her workup, and when she finally admitted, she was very upset about it because she felt that she did something wrong and now she couldn't use cannabis anymore, because anytime that she went back to it, she would have a recurrence of symptoms. But we were able to get her on some CBD oil to help with the original diagnosis, which was anxiety. And then the second patient I had could not go back onto cannabis at all, or at least THC cannabis. No, he couldn't do it.
Yeah, and I think it gets complicated if you have somebody who has CHS and they have to stop abruptly. Now you're also going to possibly have withdrawal symptoms, and it can be really problematic. But I think I've noticed, at least in my medical practice, there are some people that end up in that prodromal phase where they're not actually vomiting yet, but they have early morning nausea, maybe some weight loss, maybe some diarrhea. And so I think, it's really good to be aware of the different phases so that you can try to catch it. But I've also, Dustin and I wrote up a couple atypical CHS cases, and sometimes they can go back, sometimes they can't.
And I think maybe we should define this. Does anyone want me to define CHS? Or does everybody know what we're talking about? Okay, so cannabinoid hyperemesis syndrome usually occurs to long-term heavy THC users, and it's a violent nausea and vomiting episode that can last a day or days, and it's typically relieved by excessive hot bathing, and that heat temporarily turns down the nausea. Now, there's another clinical entity called cyclic vomiting syndrome that presents very similarly, but the difference is cannabis can help cyclic vomiting syndrome. The thing about CHS is that people don't know it's related to their cannabis. It's not like they just took a hit and the episode suddenly started. kind of appears out of nowhere. So they're baffled by it. And the kind of test to see, is this really CHS, is stop using cannabis for a month and see if an episode comes back or not. Now, in the atypical cases we presented, there were some lower GI symptoms. I believe that CBD dominant cannabis in both our cases triggered a relapse. And so some people are so ultra sensitive, or maybe it's some of these trace compounds that Daddy's waiting to discover for us, and it's not the THC at all. That's certainly possible. But I think that often, like Eloise mentioned, there's this prodromal phase where before the episode kicks in, if they pay attention, they're a little off in the morning. And if they stop using cannabis before it goes to this full-blown episode, wait a few days, then that'll subside and they can actually start using it again very cautiously, but never, in my experience, able to go up to that full high dose where they were previously. And I've had about a dozen cases over the years.
And I'd like to point out that Dr. Russo and Len May from Endocannabis Health did a genetic study to look at to see if people were genetically predisposed, and they found some very nice results. So I encourage you to read that article. I think it came out last year, I believe.
I haven't forgotten you down there, Kevin. Sorry.
I'm good.
I know the light's blinking over there, so I had a couple other questions, but let's just go with, over the past 12 years, I've seen so many changes in this industry, some good, some bad, and some really exciting times ahead. What can you all add to the future of our industry and beyond? Kevin, I'll start with you, my friend.
Well, in terms of the future of the industry, I mean, a couple things need to happen really bigly. Politically, that needs to settle down, right? Banking access, not making people criminals, not punishing parents who are giving their kids medicinal cannabis for good reason. I think those are really keys. But also, I think quality control and labeling is still an issue in a lot of states. And, I come from the natural products industry, so to me, the cannabis industry is trying to reinvent the wheel, and you don't need to. You already have a guide. The American Herbal Products Association will guide you through all those steps of what you need to do in terms of quality control and labeling and, all of this. So I think we need to learn from the existing model that's out there to improve our safety, our quality control, our adverse event reporting. I think that's really, really key. There are cases of adverse events, and we need to know who these people are and why they're responding in a negative way, and that's going to propel the industry forward. It sounds like it'll set it back, but it won't. It'll propel it forward.
Well, I just have one ask, and that is to get it off the Controlled Substance Act so we can research it.
When I think about cannabis, it seems always so perfectly fit to our contemporary problems in society, our health problems, our psychological problems. You look at this world we're living in where there's huge amounts of psychological stress, and cannabis is a solution for that, where we're kind of bathed in this environment of toxins, many neurotoxins. We have the neuroprotective effects of cannabis, and so on. It's often this solution to our most challenging problems in healthcare. And I hope that we stay open-minded and allow it to kind of evolve with some of these challenges. One in particular that was brought up earlier today is, and yesterday as well, is just the rate of mental health challenges that the adolescents in our world right now, I think are experiencing. It's just an incredibly hard time for most to be a teenager with the social media and the technology influence and algorithms, really learning quickly how to dictate behavior and kind of bring people away from their authentic self, and high stress of this kind of cognitive dissonance. We're living in a world where people are doing things all the time that just don't make any sense, and telling them to follow these things and do them, and they might know it doesn't make sense, but they're doing it anyways. So I've seen a huge uptick in adolescents in my practice, and they are, either the parents are cannabis-friendly or cannabis-curious and bringing them in because they don't like the psychiatric options that are available, or the parents are discovering that this kid is using cannabis and kind of punishing them and telling them to stop, and then watching their, kind of social interaction and grades and family communication and relationship deteriorate, and then telling the pediatrician, hey, I think the cannabis was helping. The pediatrician says, go see Dr. Sulak, and we validate what this young person has already found. So that's one example of an area where I hope we see our kind of culture able to embrace cannabis for that population as well. And I know it was very helpful for me when I was 15 years old, and I didn't have a fraction of the challenges that today's young people have.
And I hope to see more healthcare professionals become educated, because then it increases our advocacy, our opportunities for research, our access. As healthcare professionals, we often aren't able to consume if we're taking positions at institutions or organizations that try to use the 1980s Drug Place Work Act to say, you can't test positive. I want to see healthcare workers access this plant in a way that's meaningful. We have a really high burnout rate right now. We're all talking about mental wellness and how to help with the burnout. And I'm like, oh, I know. Let us all use cannabis, please, for the love of God. I think you'll see much happier healthcare workers. Not that they need to consume at work, but I want us to, we all deserve choices. So many of us raised our hands that we're patients, right? We deserve choices. So congratulate yourself for being here today and getting educated and being part of the change.
Thank you very much. We're all ambassadors for this great plant, and we're all the pebble in the pond that hits that ripple effect. So bring it home with you. And thank you all for being up here, and thank you for joining, and thanks for CanMed and all the sponsors as well. And bless you all. Thank you.
Thank you to the CanMed crew. It's been a great conference, and I think we are welcoming questions if the audience has any.
And pictures?
Yeah.
Anybody want to take some pictures of us, please? Thank you. I'm going to put it in my scrapbook.
All right, I've got a question over here. In the recreational market, we're seeing an increase in the use of nano emulsions to make the cannabinoids not water soluble, but immersed in water products. So beverages are coming online, gummy products are being made with nano emulsions. I haven't heard anybody talk about those types of products here, and I was wondering if anybody could comment on patients that are using maybe these new nano emulsion products and how the dosing of those could be different from the dose of traditional products because of more rapid absorption?
Sure. So, I think one part of that is getting the cannabinoids and other compounds into a matrix that's desirable. And, that's fine. If somebody prefers to have it in a water-based beverage and it gets in there better, that's okay. When it comes to claims about increased bioavailability, meaning, I can take a lower dose and it's going to have a stronger effect, we've seen very little data supporting any of those claims. I think a couple companies have published a little bit, and what we've seen is that there can be like a 3 to 4-fold increase in absorption from some of these nanoemulsions and other technologies. Now, it's also important to know that if you take oral cannabinoids with fat-containing food, you'll also see about a 3 to 5-fold increase. And so the cost benefit of some of these technologies, which do raise the cost of the product typically, I think we could probably just achieve that by taking it with food. And for the consumers out there, if somebody's advertising something fancy and new that's going to improve the delivery of cannabis, I'm all for it. I would just invite the company to show us the proof that it's doing what they say it's doing.
Yeah, I agree. I think there are a lot of unsubstantiated marketing claims in the industry, and working with knowledgeable healthcare professionals can really help a patient make good choices.
First, I want to thank you all for being here. I'm really excited to have you all in one place to ask this question. Over the last couple of years, with the passage of the Farm Bill, we've seen a lot of other cannabinoids hitting the market, Delta 8, Delta 10, HHC, some of those types of things. And I'd like to hear what your opinion is on some of those products that are trying to circumvent the THC laws in prohibitionist states.
Kevin?
Sure. Well, my first concern is residual solvents. that's obviously an issue, and it's been an issue in the past as well. I know in Oregon we had this problem. I think that the other cannabinoids, for the most part, we've got preclinical research. We don't have a lot of human research. That doesn't mean necessarily that, we can't use them, but if they're isolated and we can get much higher doses, I tend to fall on the safety side. These things have never been isolated, and we've never taken them at higher doses. They've always been in a mix as minor cannabinoids. So that makes me feel better to think of it that way than isolating a bunch of stuff that we've never tested on humans or even preclinical research.
Can I just chime in? So the way it's been explained to me is that the Delta-8 THC that's on the hemp market now is not directly from the plant. It goes through what's called acid catalysis from CBD to Delta-8. And the concern there is that you may convert, let's say, 80% of that CBD over, but then the rest, what are those? And they're basically saying they're uncharacterized, either cannabinoids or something else, and nobody knows so far. I'm waiting for somebody to say, oh, I figured out what those are. And the concern is, what are they, and are they safe for you? So that's the way it's been described to me. I have had a few patients use Delta-8 with some nice results with anxiety in lower doses, and especially in patients who don't seem to tolerate Delta-9, but there's still that concern of safety.
Yeah, I'm okay with people experimenting on themselves. I think life's a big experiment. That's all right. I think they should just do so with the knowledge that there's probably unidentified compounds that they're consuming, and we don't know what that's going to do to them, and it's probably going to be different from one preparation to the next.
Yeah, and I don't think our testing is very sophisticated either. So that's another concern where you can see, there was a report that came out, I think it said like 56% of at least Delta-8 products were mislabeled. We saw that with CBD as well. And there's a lot of people that don't realize that there's also likely to be Delta-9 THC in some of these products, so it can be quite impairing.
Nicole?
Hi, thank you very much for being here and for doing all that you do. My question is this: one of the things that we're finding as we speak to the practitioners is their fear of stepping into this culture. My question to you, because all of you are so open, and especially Dr. Goldstein, because this is directed for someone who we know who is a pediatrician, that we're trying to help move into that cannabis space. What recommendations do you have just to communicate to the doctors, the practitioners? Anything to kind of allow them to step into this?
So I had a little difficulty hearing you, but you're asking me what would I say to other pediatricians. Well, what I would say is your fears are unfounded, because I'm the biggest chicken around and I'm doing this. So your fears are unfounded, and it's based on research from the, Dare to Say No time, and even from before that. But everybody talks to me all the time, what about the brain development, what about this? I just don't see issues. And if I saw issues, of course I would step in, do no harm, right? So I'm not ignoring my patients, and you can tell by my slides and my talk, I am heavily involved in my patients' lives. I mean, I have some patients that email me 3 times a day with pictures. So we are I'm like closer to them than I am to some family members. If something goes south, and I stress this at every talk with the first appointment and every talk after, if there's a downside, if a side effect, anything you're worried about, there is no stupid email or phone call. You just let me know. I try to prepare people, but in general, if you are practicing good medicine the same way you practice any other good medicine, whether it's rheumatology or hematology, oncology, and especially with cannabis, it's a lot safer because you're really not going to harm anybody. You may not find the answer right out of the gate, but if someone's willing to work with you, you usually can find some benefit. The fears are unfounded, and I've been saying this for years, and yet there's still a tremendous fear factor, and part of that is the ignorance, because you don't know, because you haven't had a chance to read the research, so it's just a matter of education. But I think part of it too, someone once said to me, doctors are really good students. They're taught something once and they hang on to it for life. So It's very hard to undo.
I wanted to add to that. This came up earlier, and it's, I think, a little better for nurse practitioners, but physicians have the highest suicide rate of any profession. We are mostly damaged by our training, incredibly closed-minded and rigid in our thinking, and scared of things that we've been told to be scared of. And so we don't learn very well while we're scared. Our brains are not designed to learn when we're scared. We're designed to react emotionally. And so when you find an intelligent person that's reacting emotionally, the first step has to be to help them feel safe and comfortable and do something that will help disarm them. And I think there's a variety of ways that we can just synchronize with the person we're talking to. This isn't about breaking through to them and getting the truth to them. That's not the effective strategy. The effective strategy is basically like sit there with this scared, rigid thinking individual that's missing an opportunity to really like help a lot of people and have a much more meaningful career. Sit with them and see how you can love them. And like look at them and love them. That's probably a really nice first step that'll change the vibration in the room. And then maybe like take a different tack, like not for their patients. Maybe this could be something for themselves or for their mom who's got arthritis or someone else say no, and just kind of find where those inroads are. And I say this from experience, it's gotten a lot better. When I used to be in front of a crowd of doctors, not at a cannabis conference, but at a different conference, you could feel the energy in the room. Like, it would be so intense, the fear about the words that were going to come out of my mouth. There was no way I could teach a crowd like that, and now the work has gotten a lot easier, because people are, I think, and I mentioned this in my book, cannabis is not just a solution for the patients, it's a solution for the practitioners and for the system itself. It's a solution for their miserable practices that are, full of toxic tools that are ineffective, and it's a solution for their personal lives if we can weave it in there somehow. So those are some of my ideas.
That's great. I mean, I need to applaud that right there. Yeah. And I think so much of it is false evidence appearing real. That's the fear. For me, going now into palliative care at Stanford, I'm going to be prescribing opioids for the first time in my career, and I'm way more scared of that than I am cannabis. So, it's all about perspective.
And I want self-promotion. So I think you all have books, right?
Sort of.
Sort of. Anyway, look. Lola.
Yes. So thank you so much, guys, for what you're doing in this space. Okay. Yeah, this is really great. I hate this stuff. Okay. So my question, I'm a clinical pharmacist, a cannabis psychology consultant. I'm also a cannabis educator. So earlier when Dr. Boston was talking, she said about the route of administration. First of all, where I'm coming from when it comes to cannabis, and not even just cannabis, medication, drugs generally, I believe is all in your route of administration and your dosing. And when you look at conventional medicine, big pharmas, they have perfected the act of route of administration. And one of those areas is in your transdermal patches, like your fentanyl and suppository. Those are one of the most effective agent routes that we have. So having said that, when we look at the way we are seeing cannabis as a suppository, we have a feeling it's not really where we need it to be. Do you guys think this is an area where we can actually collaborate with the big pharmas when we eventually get into that area where we have legalization and everybody can actually come into the opens and embrace this plant? Because I really do feel that suppository is going to be a game changer, as well as transdermal patches.
I think that we could advance cannabis in that way. I have to say, in 13 years of clinical practice, I can't recall when I've been dissatisfied with my available routes of administration. What we've got right now seems to be working very well. Maybe it's not the most cost-effective, but then again, newer technologies that can enhance bioavailability, they have a cost as well. So I think we'll probably make progress there, but I don't see that as a priority in cannabis. I'm curious what my panelists think.
For me personally, I just feel like, especially when you're thinking about cancer or folks that have nausea and vomiting, especially when you are looking at the fact that when you use a sublingual route of administration, we don't even know what the bioavailability of these agents are. And we already have proven routes of administration that is extremely effective. That's why we have problem with fentanyl. That is one of the main reasons why we have problem with fentanyl, because of the way the absorption rate.
I think that when someone needs a parenteral route of administration, the lungs is ideal. The onset is so rapid, it's very easy to titrate. Again, I'm not really seeing the need. But there are some patients that do better with a patch. Eloise presented that case, and thank goodness for that ultra-sensitive outlier that there was a patch available.
And I think maybe patches, I would love to see more variety and opportunities for patches in the market. I mean, I'm very limited and they're very, very expensive, but sometimes they are game changers.
Okay, thank you guys for what you do. Appreciate that.
Yeah, and I'm just going to chime in here. I'm not anti-pharma, but I do think pharma is at the root of a lot of problems in medicine. If we try to collaborate with pharma, with cannabis, they're just going to take it away from you. That's what they're going to do. It's all about corporate. It's all about profit.
Yeah, right.
Yeah, that's it.
Oh, no,
sure.
we don't.
No, I'm not saying it's bad, but we're not being exclusive. We're being inclusive. That's the way I see it. This is a grassroots movement. It's not exclusive.
For me, I have experience both sides. I have our medicine. Now medicine as our lines of therapy. I learned how to make this up when I was a little girl. Then with my training right now, I feel like there are still the areas that
You might, the mic.
Yeah, I don't think anyone else here can.
Yeah, I'm sorry, because the rest of the room can't hear you, unfortunately, but the message is that we can collaborate, and I think that's a great one. We don't have to be anti-pharma. I don't think that's going to help us, but we have to know them for what they are and recognize the patterns of history and the way that they've behaved. We can invite them to behave differently, and maybe if cannabis becomes a bigger part of their lives, they might do that. Let's take the next question.
Thanks. Dr. Goldstein mentioned the one patient who had repeated hospitalizations, and that seemed to be solved with the low dosage THC. I was just wondering what was the actual dosage, and what would you define as that low dose range?
Sure, he actually was inhaling with a flower vaporizer, so I don't really know, but he would just take 1 or 2 puffs and he would spread it out throughout the day. So it was kind of like microdosing via inhalation all day long, and it just kept him even. And so he found that that was the best way to do it, and I didn't want to change that. I wanted him to be able to decide what worked best for him.
And this was flour, not oil.
It was flour, yes.
Okay, thanks.
He would buy flour, and he used not a Volcano, but kind of like a one-off from a Volcano type bag vaporizer.
So I have a few things to add to this. Someone asked a question earlier, and a paper came out today that may have shed some light on this. It's in Chem Archive from Munger et al., and it is vaping cannabinoid acids leads to ketene formation, which is a poisonous gas they think may have been involved in E. valley with vitamin E acetate. So encourage people, if you're looking at some of these other products, this is specifically about Delta-8 and Delta-8 acetate, which might be some of these other Delta-8s that are showing up in this acid catalyzation, but something new that just published today that may shed some light on what are in these vape pens. But I'm also going to add to this that I'm Kevin McKernan, and I'm here to let everyone know that we have finalized CanMed 22, and I wanted to thank everyone involved for it. I also have some exciting news in that many of the sponsors of this event have come back in droves with much support for next year. So we have survived COVID, which is great. CanMed will happen next year. We're still sorting on where. We usually do 2 years in each location, so it's about time for a shift. And we'll be sending out emails in regards to where it's going to be probably in the next month. With that, I want to thank all of our panelists and everyone who came. This has really been a fantastic year, long overdue, and we're looking forward to seeing everybody again at the next event. Thank you.